Welcome back, everybody. We're going to talk about all things chronic inflammatory response syndrome. Just as a reminder, this is all based on a blog series that we have on Michigan Integrated Functional Medicine that kind of walks through these. So we're going to kind of keep going forward, talking through step by step by step. And today we're talking about the CIRS treatment protocol. And so the first thing is to ask ourselves today, most people are familiar with Richie Shoemaker, his work, the Shoemaker Protocol. So Dr. Jensky, what is the Shoemaker Protocol and how does it address the fundamental issue of chronic inflammatory response syndrome?
So it's the protocol that was designed by Dr. Shoemaker to essentially identify the source of exposure and ultimately work your way up in a stepwise fashion through removing that exposure and correcting any of the underlying abnormalities. And so to be more specific, it's shaped like a pyramid. And at the base of the pyramid, it's what's my exposure or exposures and what am I going to do about it? And then as you work up, you're correcting these abnormalities and or biomarkers that we're seeing related to CIRS protocols. And so is there immune dysregulation? Are there gliadin antibodies? Are there issues with hormones and inflammation, et cetera? And all along the way, the whole point is to remove the toxins, detoxify that patient, decrease inflammation, try to balance the system best you can, get it as close to the finish line as possible. And then when able to do so, get them on VIP, which is a neuropeptide nasal spray that reverses CIRS, turns off the dysregulated transcription, turns the mitochondria back on, and in essence, essentially reverses CIRS. So the shortest version is it's the way to treat a CIRS patient from bottom up. And really, it hasn't been modified much since it was first put out there. I mean, Andrew Heyman has taken it and kind of made it a little bit more mainstream and added some more nutraceuticals and natural treatment options that we can use for some of these steps, but the steps remain the same. And the most important step, which is step one, is identify the source of the exposure and remove the patient from it or help them detoxify it in some way. So can you speak to that about sources of exposure and the importance of the removal of these biotoxins?
I mean, well, the thing about, a lot of people want to get better, but not treat the source. And so part of what functional medicine is, what we do is identifying triggers and removing them. And if you have a trigger for your innate immune system being dysregulated, being overactive, and if you don't remove it, it's still going to tickle your immune system. And ultimately, this is kind of like an adjuvant type response, which is like how vaccines kind of work. That's how your innate immune system kind of works. You had these foreign things, your body chews it up, it presents it to your immune system. And what happens with this, it's staying on one side of that spectrum. It can bleed over or pop over to the antibodies, but usually it's stuck on that one side. And so what can happen is you get this low grade inflammation, but it's not the standard inflammation of like regular blood markers. It's in your innate immune system. So hence, the person goes to the doctor, they get labs tested, they're all normal. There's nothing wrong with you because they're not looking at their innate immune system. And so you really do have to remove the exposure. And that's the reason why sometimes you can remove the exposure, but if the person has stored up so many of these toxins in their fat cells and their cell membranes, then they can feel a little better, but unless you really actively detoxify those with binders, lipid medicine, all the kind of things that we've talked about before, then you don't necessarily lower that activation of the immune system. The immune system can still stay dysregulated. Like you get a vaccine, the first time you get it, your immune system reacts. Second time it reacts more robust. Third time more robust. And so what can happen with these people is they've been exposed, they remove it, but now their body's primed. And they get exposure and they have a more robust response. And so really, you need to remove the exposure to it's the first step of the treatment protocol. It makes sense.
Yeah.
But also it gives your body breathing room to start the healing process.
I mean, it's so important because it's really the key is that these individuals don't have the ability to clear these toxins. So it's not that the exposure in and of itself is a problem, but it's the exposure and the fact that they stockpile them. So the way I explain it to my patients is we're all born with a toxin bucket. And in your case, you get exposed and your bucket fills up a little bit and you leave and you take those toxins with you. Whereas someone else might empty them out and come back with an empty bucket and have more room to fill. You come back with that bucket that's partially filled and you take on more toxins and you take those with you. And over time, that bucket's filling up. And over time, you're feeling the effects of that clinically. And we're seeing that in objective data. You're more inflamed, you're more immune dysregulated, you're more mitochondrially impaired, and that's a problem. So to not let this sinking ship sink, right? You want to patch the holes, but ultimately you got to get that exposure sorted out. And the next step is the binders, as you alluded to. Yeah. So the old gold standard is cholestyramine, and Why is that such an important binder? What are the effects of cholestyramine? What's that doing essentially for an individual?
Well, the thing that's unique about these mold, like the biotoxins associated with chronic inflammatory response syndrome, is that they both kind of have this weird amphipathic is the fancy term. They're both water soluble and fat soluble, which means they can literally cross right through cell membranes. And one of the ways your body detoxifies these types of toxins is putting it in a bottle and you poop it out. Yeah. Well, the problem with these is because they have that ability, they can just kind of just go right back in your system.
Yeah.
And so what happens is your body just recycles it. Your body tries to get it out, it gets dumped in your stool, your colon, and it comes right back in. So, and people who have the genes for this are especially susceptible to that aspect of it. So binders are kind of like cutting that whole process off. These bile acid sequestrants, they're called, they actually specifically bind on the bile. And so what happens is these particular type of molecules, they will specifically bind to them, prevent that recycling, and you poop it out. So it's literally for people who have this gene, this deficit, it's like, let me help you with this. And it's actually, they work really, really quite well. Cholestyramine being the very first one. Now we're using more Welchol these days because
nobody likes the chunky orange powder.
No one likes it. People hate it. And it comes with a nasty flavor. And they get the light
works
version.
Though, man.
It does work. Yeah, it works great. So we're using more Welchol, which is, about half as effective, as cholestyramine, if I remember that correctly. Works well, but just not as good as cholestyramine. But if you don't take it, it doesn't matter how well it works.
Yeah.
And you can also take it as a pill. But the versus, well, why don't you explain this, Dr. Jensky?
Yeah.
So we talked about these two. Well, there's all these other binders, activated charcoal and clay, and a bunch of other things. Like how is cholestyramine and Welchol, how are they different than charcoal, clay, alginate, zeolite, and all these other binders?
that are often told to patients are also biotoxin binders, which is not true. And that's one of the misconceptions. So as you mentioned, they're biosequestrant acids. So basically they're used for lipid lowering, right? They're anti-cholesterol drugs, and they were kind of used for that reason, and are still used for that reason for people that don't tolerate others or choose to not tolerate others. And then there's that off-label use for secretory diarrhea, which is how Shoemaker kind of fell into all of this. Yeah. Everybody was pooping their pants, and so they got cholestyramine, and their headaches went away, and their autoimmunity reversed, and their joint pain got better. And he was like, well, there's something to this. So basically, the way I explain it to patients is it's kind of like a pitcher and a catcher. Your liver is the pitcher, to use a baseball analogy, and the cholestyramine or the cholecylamine, aka Welchol, is the catcher. Otherwise, you get that enterohepatic recirculation that you were describing. So there's a polarity that develops, and like a magnet, negative, positive, it claps together, and then you poop it out, assuming you're pooping. Side effect of these medicines, constipation. So you got to make sure the patient's gut's working. And so in that case, it's binding truly the inflammagens that are associated, these inflammatory mediators created by innate immune activation. And in essence, indirectly, that means it's pulling toxins out as well. Whereas something like clay or charcoal or zeolite, they are not the same. They are more adsorbent or doing something different or porous in a way that they are maybe effectively detoxifying that patient for other reasons, environmental pollutants and things of that nature, biological metabolic byproducts, but they are not biotoxin inflammagen binders per se. Charcoal, zeolite, clay, they're not going to do the same thing that these binders will do, and patients are not going to have the same outcome. And so that's a little bit misleading, because there's a lot of patients that believe that they're the same, and that's not true. There is, however, a natural version that there's a good study that showed that okra and beet extract actually can help to have the same mechanism of action and binding, much weaker, but natural and more tolerable by people that are very sensitive, as the cholestyramine and cholecylamine, and there are a couple of decent brands on the market that do that. So I have utility for all those things in these patients, because they're not just biotoxic, they're just toxic. Yeah. And so you have to get them on the right binders, but you can use those other binders too. And maybe you use those other binders to decongest the system as a whole, allow their liver to be less stagnated, and then they can tolerate the prescriptive binders for biotoxin specific later on. But it's not same. And I think that's a little bit misleading.
Just a couple new nuances of that. The okra, and this was the same article that they pulled, Shoemaker and Heyman pulled up. It has about 20 to 25% of the binding capacity. Yeah. So it's
much weaker.
Yeah, weaker, but it works.
Yeah.
The other thing I think is interesting with Welchol and cholestyramine is they also remove solvents. There's actually some really great literature because of their fat soluble. And there's similar diseases like Asia syndrome, which is an adjuvant related.
Yeah.
But part of that is actually adjuvant. The original adjuvants were Froon's adjuvant, which was being primary from our studies. The original vaccines actually used petroleum distillates as the adjuvant before they advanced to things like metals and things. And so in our environment, petroleum exposure, petroleum distillates, car gas, diesel gas can actually, if you're exposed like an airline pilot, there's a thing called Biotoxin syndrome, kind of a similar inflammatory kind of responses. So that the cool thing about the bile acid, like the cholestyramine and Welchol, is they can actually get that stuff out of your body. The unique thing about activated charcoal, which I find personally really fascinating, is it two things it does. One, it actually increases your clothyr gene activity, which is a new buzzword right now.
Yeah, longevity gene.
Yeah, and it was kind of cool. And it actually binds endotoxins, which some of our patients, and this is one of the nuances with chronic inflammatory response syndrome, part of that is endotoxins, right, from the environment.
So lipopolysaccharides.
Which is a big trigger for chronic inflammatory response syndrome. So maybe some of these people have really great responses with some of those binders because they have
you treat their gut,
charcoal, and you're getting that endotoxin, which so it's cool to know all those things, because then when the patient comes in, you have to hear the story and you're like trying to put the pieces like, okay, that worked, that didn't work, that worked. And you're trying to figure out, okay, is this the building? Is it your SIBO gut issues? Is it?
And you can measure, right? You can do a SIBO test, you can do a stool analysis, you can do a Swiffer test that measures endotoxins in their home. And so if you're correlating a home environmental endotoxin exposure, or you get SIBO positive, or they're growing gram-negative bacteria in their gut, those make lipopolysaccharide, then you might layer in some charcoal. I mean, that's the beauty of all this, is you have these tools. Talk about MARCoNS a little bit. What the heck is that?
MARCoNS, it really amazes me how many people who go to mold people don't test and treat for MARCoNS. So MARCoNS is it's really important. Like the triangle, if you go to the website,
it's the bane of my existence.
It's the bane of So, but it's an important part.
Yes, it is.
But it's multi-drug resistant Staphylococcus aureus that releases hemolysin, which are chemicals that actually affect MSH production in your brain. Actually, the POMC molecule, which is the same molecule, turns into makes cortisol, CRH, also affects alpha MSH, melatonin. It's like a really, really important molecule. And the toxin made by this thing in your sinuses actually messes all that stuff up. It can increase people with pain syndromes, chronic fatigue and fibro. It can affect your sleep quality. It affects some of the downward inhibition, like the Shoemaker talks about the regulation. Part of that that's coming from midbrain is actually affecting that via MSH. And so if you don't test it and treat it, that can actually keep your MSH suppressed, which ultimately affects your natural killer cell count, your immune system. The natural killer cell count is downstream, innate stuff. Upstream is more like the MSH kind of stuff. And so it makes it hard for your body to heal. And I've had patients, you probably have as well, who I've go do a binder, treat the MARCoNS, and all of a sudden they're like, oh my gosh, I feel so much better after this. It is the bane of your existence, because
it's always possible.
It tends to come back. It can take a long time.
It takes a long time to treat. It also affects gut, right? So tight junction dysfunction, which could potentiate or spark off autoimmunity in someone. It affects androgen levels, suppressing those. So I think about something that's going to cause you to be more tired, cause you to have more pain, cause you to sleep poorly,
hormones
suppress your testosterone and your guts off. Like, that's probably important. And there it is. And really the reality is you get the biotoxin exposure, MSH comes down as part of that pathway. And now you're susceptible to colonization of MARCoNS, which suppresses it even more. And now you're going to chase your tail phenomenon. So I don't know how you don't diagnose and treat it. The problem is treating it. So how do you go about treating it?
There's been a lot of variations, and originally we're using BEG, which was bacitracin, EDTA, and gentamicin. And unfortunately,
I still use that a little bit. I'm concerned about the ototoxicity, but I always disclaim to the patients.
I actually had one patient lose hearing from it. So
I have a couple that have said, you know what, I got a little tinnitus, so I'm going to stop it. And the rest do fine on it. And I use it very sparingly in I've been on EDTA for 6 months and it's still not going away. What are you doing differently? And if it's sensitive to gentamicin, which you can see on these MARCoNS swab results, right? You see sensitivities, you see resistance patterns, then I might use it.
So then we kind of,
with consent, obviously.
Of course, of course. Informed consent. And so then we kind of moved to more using a combination of EDTA and colloidal silver. And then now we're using more just plain EDTA, which is a biofilm buster. I tend to use that and add on colloidal silver to it because, as you alluded to, it's just really hard to clear. People, the technical protocol, which is one of the sticking points, is you do this for 6 weeks and then retest them. And I stopped doing that early on because I realized it's taken 3, 6, 9 months sometimes for people to clear. Personally, this is anecdotal, but personally, I actually cleared mine, MARCoNS, with betadine. I just switched out the colloidal silver, one metal with another metal, and used a neti pot.
Yeah.
Was actually able.
I can't use a neti pot. It chokes me out.
There's a new one actually, in Greece that Becky introduced me to. It's my wife. And it's actually it's almost like a gravity fed neti pot.
Oh, cool.
And so what happens is it takes the water, it puts in a column up, so it gives you a little bit of gravity.
Yeah.
So it gives you a little bit of pressure, not too much. And you push the button on top and just goes through.
Well, I have patients do that, and they use the Biotoxin liquid. I have them do that sometimes. I've heard patients did on their own using some iodine.
There's a new thing one of my patients told me about, because she called the people from MicroBioDX, and they're recommending, because some of the people do the culturing using ACS Supreme or yes, it's
silver.
It's colloidal silver, but they also have echinacea, a couple herbs in there.
Yeah. So X-Layer, which is xylitol, is a biofilm buster that you can use, and that sometimes has grapefruit seed extract in it, some other things. I think they make one with echinacea. And then Citri drops, which is homeopathic, but very effective, and was designed by an ENT in Georgia who treats a lot of MARCoNS
What's
patients.
the name of that one again?
Citri drops.
Spell that.
CITRI drops.
Okay.
It's microbiologicalformulas.com. They always run out, and then they restock, and then they run out, and then they restock.
It's a pill, like
it's a nasal spray.
Nasal spray.
It's basically homeopathic citrus. It's antifungal, antimicrobial, has some biofilm disruption. I have some patients that are intolerant of the EDTA, even when I go really low strength, that they do well on the Citri drop. So it's a crapshoot. You got to use a lot of different stuff.
So what I'm hearing is we're willing to try whatever.
Yeah.
You got to get it
going.
You got to get going. Fair enough. Okay.
And most importantly, if they have an ongoing exposure, they're probably not going to eradicate the MARCoNS. So get the exposure right, because that might be the issue.
So we're back to step
one, right? That's why it's step one. Right? Get the exposure right, then maybe reassess the MARCoNS. And sometimes in rare situations, the patient might have a root canal gone wrong and a cavitation that's harboring the bacteria, and that needs to be addressed. And so sometimes that's a possibility.
So part of the Shoemaker Protocol is actually eliminating, getting your anti-gliadin antibody down, which is related to like wheat, gluten, celiac kind of stuff. Why don't you talk about that a little bit? Because it's not celiac disease, but you have to remove gluten. So why don't you kind of walk us through that? Because that's an important part of the
So, I mean, really, all my CIRS patients are gluten-free for that reason. I measure the gliadin antibodies, even if they're negative. I just say, don't eat gluten. Your gut's already leaky, because we talked about how suppressed MSH is going to do that. I essentially tell them your tight junctions won't work until you're out of CIRS, even though you're doing all the right stuff. We can get them better. It won't get across the finish line. The last thing you want is something that's going to propagate, potentiate that. And we know gliadin does that. It's the protein from gluten. And when you see these antibodies, it's a conversion that's presenting like non-celiac gluten sensitivity. And therefore, like celiac, although not autoimmune per se, it's the cure is avoidance. And so strict avoidance of gluten and cross-contamination so that their gut can heal and calm down. Because the last thing you want is potentiate that to the point now that if they have the gene, that now you're triggering something like celiac to fire off. So I just make those patients gluten-free.
The thing about gluten, everybody gets a little bit of leaky gut with gluten.
Immediately.
So it's one of those things, if you've already got gut issues, MSH is already low, which you're propagating that a little more, then eating it is just going to make your healing process, And one of the, step one in healing is remove, if there's something stopping your body's natural healing process, remove it. If your body's lacking something, give it to your body. And your body has this amazing ability to self-heal and self-repair. But the first step is going to be remove that thing that's blocking your body from healing. So
and then I'm going to leapfrog the question about androgens and hormone imbalances. I mean, I feel like we can talk about hormones all day, and that's something that we can touch on. I want you to touch on the ADH osmolality dysfunction that we see, because I know that you speak on a lot of our social media channels and have done blogs on dysautonomia and POTS, and I consider you to be one of the leading experts in this area on this. And so I'd like your thoughts on kind of some of the ADH osmolality stuff that you're seeing, and how this is a little bit unique in how it affects almost a POTS-like or dysautonomic picture that in this case is potentially reversible, which is pretty amazing.
So the ADH to osmolality, what happens is because of that dysregulation, again, the regulatory part of your brain, ADH, cortisol, those regulatory centers. That's also where your other hormones get regulated, become dysregulated. So one of the effects is that your body has a hard time recycling water, basically. And so the phenomenon is people drink water, like I'm drinking water, I'm thirsty, but I just pee right out. And it's really an interesting phenomenon because one of the effects of that is you get hypovolemic. Your water volume actually goes down, and the cells actually become dehydrated. And one of the effects is actually the sodium chloride, the salt in your skin goes up a little bit. So it's really a bizarre phenomena that people actually will conduct static electricity more. So one of the questions you ask people when you do the intake, the cluster analysis, is do you get shocks? And it's really bizarre how the ADH osmolality can actually affect how well you hold and create static electricity, so much so that during the wintertime around here, people will be like, oh yes, I shock everything. I never thought about that, right?
No one ever does, yeah.
Yeah, and sometimes it will be to the extent that people actually will mess with electronic equipment. And so walking back, that ultimately is our body's inability. You're actually developing a type of dehydration, and you drink water, which dilutes out your electrolytes, and it gets even worse.
Yeah.
And so what can happen is you get this POTS-like phenomena. There's 3 types of dysautonomia, right? I'm sorry, 3 types of POTS. One's autoimmune, one's neurogenic, and then one is neurogenic, autoimmune, and adrenal. And so what happens is this one it looks like that, but it doesn't fit the same kind of paradigm. People can still get better if you do the electrolytes, right? Which is helpful, and you do the fluids, but you really need to address the whole mold kind of thing.
Yeah.
What can happen, however, is this is one of the unique things I've discovered is there's this, well, I haven't discovered this part. This is part just in one of the weird worlds that we kind of live in. There's this thing called the pentad super syndrome, which is hypermobility, dysautonomia, GI dysfunction, autoimmunity, and mass activation. Yeah, thanks for that. So when you see one of those, and then 6 and 7 are cranial cervical instability. There's a bunch of other things outside of that. But one of the things that sets people off this is hypermobility, which about 20% of our population is hypermobile. So all of a sudden, someone's in a multi-building, they start developing POTS and dysautonomia, go to the POTS experts, and they're like, let's do IV fluids, let's do Adderall for your brain fog, let's do midodrine to get your blood pressure up, or whatever. And the triggering event is actually mold.
Yeah.
And so all of a sudden, when I see these dysautonomic patients, and we've learned from the pandemic, you can actually have the COVID vaccine can be a trigger for dysautonomia. So can COVID. We've known about that from other viruses. People get like the flu and they get dysautonomia, get concussion, get dysautonomia.
Yeah.
Well, concussions are one of the peripheral CIRS phenomena, right? There's like the 80% water damage building, then 20%, and that 20% concussions, head injuries are one of those. So all of a sudden now we're seeing links between like what we thought were standalones, dysautonomia POTS, and they're not, they're linked. And so now when someone comes in and they have dysautonomia POTS, I'm like, okay, stepping back, is mold at play here since half of all buildings have water damage, right? Or any other of these CIRS phenomena, which include endotoxins, and that's where you get into some of the gut stuff. Yeah. And with dysautonomia, there's an interesting case in Texas that had a patient cured with POTS, and they did IVIGG, low-dose naltrexone, which we use a fair amount of. They treat SIBO. And in my mind, that's all of a sudden, okay, gut stuff, endotoxins, immune dysregulation, TH1, 2 with the low-dose naltrexone, and then IVIGG is immune modulation. All of a sudden, that's with that. Okay, all of a sudden now, how can we connect those dots for some of our patients? So the ADH osmolality, I think it's intriguing. I did do some patients try nasal
desmopressin.
It was helpful, but ultimately it's like you really, to get that, I will do one thing, and this is not part of the Shoemaker Protocol. For those people, I will give them cell salts. I'll do potassium citrate, magnesium citrate with trace minerals. I'll try to alkalinize the urine, which helps improve the redox potential. And that's all put into the fluids they should be drinking, 1 ounce per kilogram of body weight of fluids at least. And then if they need extra sodium, I found out with that actually is can be just as beneficial as people who do all the salt pills and stuff. That by itself can actually help improve some of their cell redox, cell function, while you're like eliminating the mold and treating the MARCoNS and doing the binder, and it gives people an extra kick in the body, which it's cool.
Instead of being idle and being so symptomatic. I mean, I've had patients come in with POTS diagnoses I've had 2 to date, and that doesn't seem like a lot. But when you come in having seen a POTS expert, who are rare, and you're seen as a fringe patient and you're on all these weird meds and you can't walk around the block without passing out or almost passing out. And then you get through Shoemaker Protocol to VIP and reverse CIRS, and you're off your meds and you write me a portal message saying, I just hiked the Blue Ridge Mountains.
It's kind of
I
cool.
would consider that a cool cure.
Yeah.
And I've had 2 cases like that. So that's really cool. And so I think that until you don't know what the underlying etiology of what your condition might be. And a lot of times biotoxins are the answer. And I think that's a big deal. All right. What else?
I don't,
You want me to touch on the hormone stuff a little bit? I mean, really,
I think that's probably, that's not on the question list here, but I think talk about that because it's an important part.
Yeah.
I'm not sure we want to dive into VEGF too much and then
Yeah.
MP9.
I mean, they're just
I think hormones. Yeah.
the VEGF and the MMP9 just briefly are just kind of some of the biomarkers that we're using to make a case report. And eventually they're going to correct over time. Now, if they're abnormal and they're progressively getting worse, you probably need to intervene. That might be a little bit beyond the scope of what we're trying to do at this point in time.
Yeah.
But with regards to hormones, I mean, I feel like everybody kind of has a hormone problem. And we're talking about, in this case, things like sex hormones that we see these abnormalities, in particular androgens. And so that's the global term for what we would say as male sex hormones, so testosterone and things of like that nature. So we see them suppressed. And so how many times do you see in your practice, and I've backed into a source diagnosis this way, a metabolic patient who has, a little bit of hypertension, a little bit of that spare tire, their testosterone's low, and you're just assuming this is because this person's not eating right and they're not exercising, they're stressed out, and their hormonal pyramid is off, and now he's got to work on X, Y, and Z. And it turns out that they're a biotoxin patient. And I've had that happen a couple of times. And really the reality is that testosterone can kind of autocorrect as you work your way out of the system, but you can benefit them by doing the low-hanging fruit, which for me is making sure they're getting adequate protein, making sure they're getting some resistance training, getting adequate zinc, managing their stress, optimizing their thyroid function. And then do you want to do some things that might boost their thyroid or their testosterone naturally? I like libido stim or tea time or something along those lines. But in a younger male, you might consider something like clomiphene or N-clomiphene. And in an older male or younger who doesn't want to have children, you could even do testosterone replacement. But that's really not anything I would do early in the course of this treatment. You want to really start with the biotoxin stuff because you really see a lot of autocorrection along that way. And so the process is really about going in that stepwise fashion. And you can see this improve as MSH comes up, as that ACTH cortisol loop starts to balance out, as their gut starts to heal, as their nutrition starts to improve. And you just kind of see that kind of.
No, the way I want to end, the last thing I want to talk about is the tip, the VIP. You know, and you've said one ton about VIP in the past, how it resets the genes in the brain and how it's like amazing. It's the icing on the cake kind of thing. I don't want to talk about that stuff, but I want you to tell us like your experience with using it. And what you've seen with the use of VIP, because that's, I think people get all the fancy stuff, but like, what you've seen it actually with.
I've used it. So, and it's not because I was experimenting with it, it's because I had CIRS. So, it was a game changer for me. I mean, the main reason I came to see you is because my brain stopped working, and I had all the things that I essentially were just attributing to poor lifestyle choices and getting older. And the reality was when my brain was basically broken is when I said something's not right. And you said, yeah, you're moldy. And I was like, okay, what does that mean? And I got the little lecture and hence here we are. And so, as I got on VIP is when I really realized the true nature of the extent of what was going on in my body. Because it was for the first time in probably, I want to say 15 years that I felt switched on. It was literally akin to a light switch. I woke up and I felt like my brain's working again. I'm thinking more clearly. There's my memory. There's my recall. There's my ability to learn. There's my energy. And so you feel this graded, sometimes precipitous improvement in all the manifestations that you should expect if your mitochondria are healing, if your brain is repairing, and your immune system is balancing. Think about the global state of those 3 things. If your brain's on fire and that's put out, and then from those ashes, you're building new brain tissue, because that's truly what VIP can do. If you have dendritic pruning that isn't irreversible brain damage, VIP is repairing it, and the volume loss becomes volume expansion and normalization. I took a brain damaged patient and brought them back to normal. I don't know of anything else that can do that. If your mitochondria don't work, you don't work. Period, hard stop. It's not just the power plant in the cell. It is the sensor. It's the canary. It's the canary of our cell, sensing internal environment, sensing external environment, and then informing the cell, this is what we should be doing. And in the case of a biotoxin exposure, that information is duck, get into battleship mode. We are in a cell danger response. And when you're out of that and VIPs turn them back on and they're cloning out, you get mitochondrial biogenesis, all of a sudden that signal is, let's make energy, party time, right? You feel switched on. So I just remember feeling like I got myself back. I remember feeling like this is who I knew myself to be when you know that moment when you ask patients, when was the last time you felt well? And everyone kind of hates that question, but it's an important question because an establishment of a timeline, it tells you when things might have really gone wrong building up into that point. When you get on VIP and you reverse your CIRS, you get back to that, this is when I last felt well. But then you build upon that and you actually feel even better. So for me, it was akin to a light switch. It was transformative. It gave me my life back. It gave me my brain back. It gave me my health back. And it gave me the realization that what I was suffering from was something that was correctable and not this sentence that you're often told you have by conventional medicine. Sorry, that's your lot in life. Sorry, that's genetic. Sorry, that's idiopathic. Not okay. I wasn't okay with it. And we fixed it. And I mean, that's really my thought on VIP.
Cool. Gotcha.
Yeah.
So that's our walk through the Shoemaker Protocol.
Yeah.
Going through piece by piece by piece. Hopefully that was helpful. Again, refer back to the blog series on this. And next, we're going to talk about the appendix, which is a potpourri of some things. And hopefully we can get into some other kind of topics as well. Goal is to give everybody a really well-rounded understanding of chronic inflammatory response syndrome so they can be the healthiest version of them that they can be.
Yeah.
All right. Take care.